Good evening, everyone. If everyone has seen the poster which came out with the pro-con session at the bottom, anyways, my good friend Meenakshi is going to talk against the topic, which I'm going to propound that SGDs are safe for obstetric general anesthesia. And at the bottom, interestingly, the organizers had put up the image of two tigers. They were actually romancing more than fighting. Therefore, at the end of this session, we don't intend to fight at all. We are going to give you data or facts and then see whether the SGDs can be used or not. Yeah, thank you, AOA, for giving me an opportunity to be a part of this virtual conference. And I'm sure I will try to do some justice to the topic given to me. And I will try to come up with evidence to say that supraglottic airway devices are safe for obstetric general anesthesia and it can be routinely used with some caveats though. Okay, it is time to debate. As I said, we are not fighting, we are only here to debate. Thanks again for the opportunity to be on the side of logical conclusion on this topic, because of late, over the last 10, 11 years, there have been quite a few articles published and literature on the supraglottic airway devices which can be safely used in selected cases. That also we'll discuss towards the end. Start with the introduction. Difficult intubation, as you are aware, has been reported in about 0.45 to 5.7% of intubations in pregnant women. And it's almost the same with the general surgical population. It's about 5.8%. But please remember that the consequence of difficult intubation can be greater in the obstetric population. That is what worries us, because it's double trouble. And then we have to take care of the laboring woman and the baby who is yet to see the life. What are the issues with difficult and failed intubation in obstetrics? The rapid onset hypoxemia after induction is a possibility. Difficulty in inserting a laryngoscope blade because of the anatomic changes in the laboring woman. Poor view at laryngoscopy, edema and hyperemia causes increased risk of bleeding from the airway manipulation. And full stomach, we'll debate that at the end. In pregnancy, it is conventionally taught. The failed intubation drill actually talks about the alternative laryngoscopes. Failed intubation, can I ventilate? And there we are. Supraglottic airway devices have been a part of the failed intubation drill and difficult airway management in obstetric practice all the while. As soon as the supraglottic airway devices came into the market, we have been talking about supraglottic airway devices as a part of the difficult airway management. And we will focus on that. Again, statistics. The obstetric patients have been reported to have failed intubation rates from about 0.18 to 0.56%, but surgical patients, it's only about 0.045%. Therefore, obstetric patients, you can encounter more failed intubations. We'll start off with evidence from this particular article, which came in Saja in the year 2015, where Bishop said rapid sequence induction, while still the standard of care for airway management and obstetrics, is no longer considered to be essential in all cases. And supraglottic airway devices are being used in subcategories of patients as a first-line airway device can be used. That is in 2015. Go back to Mendelssohn, which is absolutely a landmark article which he published in the year 1946, where it said the regurgitation and aspiration of the stomach contents into the lungs caused mortality. When he talked about 44,016 cases undergoing general anesthesia, please remember that it is with an ether. We know that ether is a potent emetic, and there were 66 cases only of aspiration and 2 mortalities. And please remember, both the mortalities reported were due to solid food aspiration. Therefore, we have to change our practices And this too, when we talk so highly about Mendelssohn syndrome, the incidence was only 0.15% of aspiration, and two mortalities. Mortalities were both because of solid food aspiration. And we don't use either of the inhalational agents now. Ether is obsolete and nitrous oxide too is hardly used. Therefore, the practice have changed, so too the evidence. We'll ask ourselves a few questions and try to find answers in the literature. Do all obstetric patients require rapid sequence induction? There is evidence to say that the rapid sequence induction, when you try to apply cricoid pressure, that distorts the anatomy, laryngeal anatomy, and the mask ventilation becomes difficult. Laryngoscopy and rescue strategies in failed intubation also becomes very, very difficult. Therefore, rapid sequence induction as a general strategy for airway management in the patient at risk of aspiration has received a lot of attention over a period of time. The references are given down below. And there is a kind of conclusion to say that it need not be. Rapid sequence induction remains standard of care for the obstetric patient who is at risk of aspiration. We'll talk about that as we go by the risk of aspiration. Appreciation that not all obstetric patients are at risk of aspiration is an important development in recent years, and thus true rapid sequence induction is not required in all patients. We also talk about gentle mask ventilation when we talk about the rapid sequence induction, which has become modified rapid sequence induction, MRSI, and we give gentle mask ventilation. We squeeze the bag in spite of applying cricoid pressure, and more so in obstetric patients, given the reduced time to desaturation following apnea. Therefore, rapid sequence induction, do you sincerely do it or not, is a question mark. The next question would be, do all obstetric airways require endotracheal intubation? I will take you to this article, which was published in Anesthesia Intensive Care in year 2010, where Halase used LMA Procil in 3,000 parturients. And he selected his patients, of course, where the BMI was less than 30 kilograms per square meters. And the patients did not have factors for regurgitation or a difficult airway. But the technique was a little different. They used rocuronium and a McIntyre laryngoscope and a Magel's forceps. But Procil LMA was placed in 3,000 patients. That is still date the largest series of patients where the patients were not tubed and they used supraglottic airway devices. Interestingly, they reported a 99%, almost 100% first insertion rate, and there was only one case of regurgitation into the upper airway, but without the clinical sequelae. The patient did not have an aspiration, it was only a regurgitation. And none of the patients out of 3,000 parturients required rescue intubation. Therefore, we can safely say that not all the patients need endotracheal intubation. You can also manage them with suprachlorotic airway devices. Is it time to revisit tracheal intubation for cesarean delivery? There have been quite a few articles on this. Start with Yav et al., who used the LMA Supreme on about 700 parturients and have minimum of 4 hours. And again, they selected their patients. The patients fasted and the BMI was much lesser. And he used anti-aspiration prophylaxis in all these patients. Evidence of aspiration was not observed, and all of them were successfully managed with the LMA Supreme. There were no complications such as hypoxia, laryngospasm, or bronchospasm. First time successful insertion occurred in 98% of the subjects, and the insertion time was 19.5 seconds. And the gastric tube also could be inserted through the LMA Supreme. By the way, we can also do a bronchoscopic intubation if needed via a supraglottic airway device, and it has a high success rate if needed. And none of the studies which I talked about till now, they used it. Can iGel replace endotracheal tube during elective cesarean sections? We talked about LMA Supreme, we talked about Procil. Now, can iGel to replace? Its use in elective cesarean deliveries has been shown to provide comparable control of the airway, but was associated with fewer airway complications such as bronchospasm, sore throat, regurgitation, and dysphagia. Therefore, can we again say safely that iGel can be used versus an endotracheal tube? Yep, maybe yes. We'll come closer to our land. Our own journal, Journal of Obstetric Anesthesia and Critical Care, there was an article in the year 2016 where they compared 60 patients, laboring women for C-sections. They used Procel, LMA, and endotracheal tube. And the 60 patients, the findings of the study was that the insertion of Procel LMA was quite easy. They took only about 20 plus or minus 6 seconds. And the endotracheal tube insertion time was almost the same, 18 plus or minus 5 seconds. And adequate ventilation was achieved with a very minimal hemodynamic changes with PLMA. Obviously, the endotracheal intubation will cause a rise in the heart rate and the blood pressures. And there were no regurgitation, the incidence of regurgitation with the use of Procel LMA. For the authors concluded that PLMA appears to be a safe alternative to endotracheal tube for selected obstetric patients undergoing elective LSES. Our own Anjan Trika wrote an editorial in the same journal based on this. We will talk about that a little later. And after discussing about this paper, which appeared in BMC Anesthesiology in the year 2009, where they compared Supreme versus endotracheal tube, and their findings again were, it was an RCT, and findings were quite interesting. They said that time to effective ventilation was much lower with LMA Supreme. It was only 16 minutes versus 9 seconds with endotracheal intubation. When you go down, the systolic and pressures and the heart rate both went up massively with endotracheal intubations rather than with placement of a supraglottic airway device. That also to be expected, and that is what happened. And talking about the fetal and the maternal outcomes, I think was comparable. The APGAR scores were comparable, and the presence of blood on the airway device was in 6.1% in Supreme, LMA Supreme, and 7.8% with the endotracheal tube. Obviously, endotracheal tube may cause more trauma, therefore that's possibility. And incidence of sore throat again was higher with endotracheal intubation. The patient satisfaction remained the same, and volume of gastric aspirate was almost the same, 17.3 to 17.6. Therefore, res ipsa locutor, SGDs are safe for obstetric general anesthesia. We have enough evidence to say that it can be used in selected cases. All right. What are the benefits of routine use of supraglottic airways? It's easy to train. The efficiency is more easy to coordinate, and then it enhances the safety. But I will make Meenakshi's job a little easier because it has to be done with caution. You cannot be jumping on every patient and say one size fits all and then try doing this on every patient. We cannot. I mentioned about this editorial in the same issue of 2016, the first issue of Journal of Obstetric Anesthesia and Critical Care. Anjan Trika asked a question: routine use of laryngeal mask airway for C-section, is it time to reconsider? As I said, caution was the keyword. Careful patient selection and adherence to strict protocols are necessary to ensure safety. And he also said that strict criteria to diagnose regurgitation and aspiration should be included in the protocol during the initial phase of implementation. You gain the confidence. You cannot be routinely doing it and you rest forever, right? There is an aspiration risk in obstetric patient according to, we knew it from time immemorial. And a study by Olson and colleagues in 1986 reported an incidence of pulmonary aspiration, which was quite high, 1 in 661. But now we talk about 1 in 1095 to 1 in 4,500. And actually, the guidelines have been changing, obviously, as the medicine advances, the drugs. We have safer drugs, safer techniques. The guidelines do change. And American practice guidelines are quite rigid vis-a-vis National Health Institute of Healthcare Excellence guidelines, where we talk about intrapartum care of pregnant women, recommend allowing women low risk labor to drink and have a light diet. and those with high risk labor to drink only. American guidelines, they don't allow them to drink and eat at will, and they also talk about non-particulate antacid prophylaxis, H2 blockers or prokinase. But we have been doing say first. Compared with the tracheal tube insertion, this is the kind of a meta-analysis of all the papers, where when you add up, it's more than 8,000 patients where the supraglottic airway devices have been used. And the advantages of supraglottic airway device placement is it requires less expertise and less time for insertion, and is associated with fewer complications, especially at extubation and in the postoperative period. We can think about using SGA in obstetrics, but it is limited to it was limited to airway rescue after failed intubation. But now we have changed towards not routinely, but in select cases. And as I said, the biggest single study was 3,000 cases Halase et al. Published. There was only one incidence of regurgitation, and again, no aspirations there. Okay, there were a lot of papers again. Then I will try to bust the myth of the full stomach and regurgitation and aspiration because of the full stomach. The term full stomach is an oversimplistic convention. How about the dichotomized opposite, the empty stomach? This is not as inaccurate, to be sure, but it may still not be the whole gastric secretions and volume. Even when there is no oral input, the volume of the stomach contents were found to be lower after drinking 150 ml water than after remaining meal by mouth. The gastric juices contribute more volume than 150 ml of water prior to anesthetizing, which will push the gastric juices down into the gut, and the stomach emptying also, gastric emptying also is haze, and because of the water, therefore the full stomach is something which is arguably to be considered in a single center prospective study. I'm sure Subramaniam would have talked about this paper where the gastric volume was tested studied in patients and with an ultrasound, and baseline gastric volume of pregnant patients was not significantly different from that of non-pregnant females. And therefore, if you run an ultrasound in, as Dr. Subramaniam said, in a semi-recumbent position, the 45 degrees head up, the cross-sectional area at the antrum, the 95th percentile of antral CAC in healthy fasting term non-laboring pregnant patients is about 8.7 square centimeters, which corresponds to a volume of 150 ml or 1.4 ml kg. They are not significantly different from those of non-pregnant women. You look at the graphs of CACA or volume as presented as mils per kg or volume as, at last 2 minutes, I will just finish off. The histogram shows that there is not much of a change between pregnant cohort and the non-pregnant cohort. Therefore, are we really worried about the full stomach in patients who are, only when you are worried about the full stomach and regurgitation and aspiration, we think about rapid sequence induction and intubation, and then the intubation basically. Okay. This also is an article Dr. Carvalho wrote in Anesthesia in 2018 to talk about predictive values for gastric antral cross-sectional area and the volume. And the authors recommend that 9.6 centimeters square in the semi-recumbent right lateral position is something which goes well. 9.6 square centimeters and about 115 ml of whatever the airway strategy modifier of airway management in pregnant women should not go against decades of improving maternal safety. From higher mortality rates and morbidity rates, we have achieved what we almost want to now, and then we should not throw it all away just because we want to be venturing into something else. Therefore, even when I say that the patient is, it can be, supraglottic airway devices can be used in cesarean sections, patients coming for C-sections, but please select your patients well and make sure that they're at lower risk of regurgitation and aspiration. Then only use supraglottic airway device as the first line of management, safety, and select patients well. Thank you very much.
Thank you. At the outset, I thank AOA for having given me this opportunity. And I thank my friend, Dr.Madhusudan Upadya, who is one of the handsome anesthesiologists in the country, who has consumed 20 minutes of time.
Oh, sorry.
I will not consume that much of a time. To tell the truth, I need only a few minutes. That too, he himself has concluded that it should be used with caution. Exactly, that's what I want to say. And whenever a debate occurs, the debate itself says there is some element of doubt in that. That is the reason why the debate comes. It is not a foolproof. So with that in mind, I am telling you, the supraglottic airway devices, first, the placement can induce vomiting, which is deleterious in the pregnant women. The idea of pro and con debate is pro, they will tell the advantages, and con, they will tell the disadvantages. And it is for the viewers and the postgraduates to decide about the pro and con of every subject, every equipment. So the aspiration of gastric contents is not prevented by these supraglottic devices. Then improper positioning of the supraglottic devices, it leads to gastric insufflation. It is not that easy to place the supraglottic airway devices. That too, it is in a blind technique. Then if you remove it and again insert it, remove it and again place it, then the multiple insertion leads to airway trauma. So by getting a successful placement, you may induce more trauma to the airway. Again, even with that, the intermittent positive pressure ventilation is very, very difficult with the supraglottic airway devices. And I am sure all the anesthetists would have felt there should be some amount of leak. The hissing noise will be there very frequently with LMA. Why the IPPV is limited in SGD? Backfolding of the distal cuff, occlusion of the glottis by the distal cuff. Then there is complete downfolding of the epiglottis sometimes. Sometimes the mask itself will rotate its long axis. This is not told by me. The British Journal of Anaesthesia gives this picture how many ways the supraglottic devices can be malpositioned in the throat. So when this much of a possibility is there, then imagine how you can ventilate the patient with supraglottic devices. I know Dr. Madhusudan will give so much of evidence, and I could not compete with him in intelligence or subject. So I borrowed a few lines from the Chestnut's Obstetric Anesthesia. So he cannot make a comment on that. See, with the possible exception of ProSeal, and LMA does not protect against pulmonary aspiration. With the possible, it is not informed by me, it is by the Chestnut. So the continuous cricoid pressure may be maintained after placement of a LMA in obstetric patients. It is also told by the Chestnut. Not only that, it says insertion of LMA in obstetric patient who can easily be ventilated by face mask is controversial. So if a patient could be ventilated by a face mask, then LMA is not needed because little additional ventilation benefit is achieved. It is by Chestnut obstetric anesthesia. So if you could ventilate the patient with face mask, then insertion of LMA is not needed. So it is something is better than nothing technique is to be used only when there is a risk, when there is a failed intubation. See, again, the Chestnut says in experienced hands, an LMA is effective and probably safe. In experienced hands, probably safe, and in selected healthy patients, imagine three adjectives: experienced hands, probably safe, selected healthy patients. So if the anesthesiologist is experienced like Madhusudan, it will be effective. But like me, inexperienced, Madhusudan is inexperienced state, but myself inexperienced state, this may not be that much effective. So you have to be very careful in that. And many case reports have described the use of LMA as a rescue device, not as a routine device. It is a rescue device. Then, as he said, through fiber optic, intubation could be done through LMA. No, intubation through LMA has a low success rate. Again, it is told by Chestnut Obstetric Anesthesia. It is not informed by me. Then the Journal of Obstetric Anesthesia, Dr. Madhusudan quoted this, so I have included while he was talking on that. This is a official publication of AOA. So what this says, this is the he has quoted only the first 3 lines. See, the conclusion says ProSeal LMA is designed to provide better protection of the airway, right? To provide, but it appears to be a safe alternative to ETT. It is not the routine, it is an alternative. It is mentioned in the same article. A further study with a large group of patients is required to establish the safety. It is mentioned in that. So Dr. Sunil Pandya and his team already decided these supraglottic devices are to be alternative and they should not be a routine device. Again, the BJA, supraglottic devices for cesarean delivery, for all, for none, or for some. It is the title. See, they are giving the result. Patients should be selective. They are selecting in so many ways. Patients should be ideal weight. It should be fasting. So many conditions. It's very difficult to select a patient like that. Then ultrasound abdomen. Dr. Subramaniam Mahankali has talked about this. How routinely, even Dr. Ketan has asked, how routinely you can perform ultrasound abdomen to detect gastric contents. Again, even if it is done, it is only selective. It is not a routine. Then it should be a rescue device if intubation fails, the BJA states. Then the obstetric airway management, it says SGD is to be used as a rescue device, not as a routine device. Then some people can claim the endotracheal tube. Why we are against endotracheal tube and pro person is talking about LMA? They may say sore throat, but it is a small price for a big safety because it is life. It is life. Then they may say the endotracheal tube at the time of extubation or intubation, the patient can develop laryngeal spasm, but it can occur in supraglottic devices also. But the main difference is endotracheal tube is protective in laryngospasm, but supraglottic device is not protective in laryngospasm. Again, I want to tell you, endotracheal intubation is under direct vision, whereas supraglottic device is a blind insertion. However experienced you may be, it is only blind. Rather, I can say it is double blind because we don't know where exactly it is positioned. Even the patient is not aware where exactly it is positioned. So it is only double blinded technique, the insertion of LMA. When we have vision, why a blind technique? That is my question. We have a vision. Why there is a blind technique? So then you cannot verify the position of supraglottic device also. That is a problem. So when the vision fails, this blind technique can be a rescue device, but as a routine, we cannot be blind. At times we can be blind, but as a routine, we cannot be blind. And I want to give a word of caution. Anything new would be attractive, whether it is LMA or your ProSeal. It is attractive, but we have to think and decide whether it is always attractive or it is giving some problem. So the thing, in 1870, the Trendelenburg first intubation was done in man. So it is in 1870, long years of relationship. It is a tested relationship, trusted relationship. It is not the moment of attraction. See, in 1878, anesthesia intubation was done. See, it is more than 100 years. We are loving endotracheal tube and still we are loving endotracheal tube. So just because a new equipment has come, don't be get diverted. They may be used sometimes. I'm talking about equipments only. Don't take it otherwise. I'm talking about equipments. They may be used sometimes, but this is a trustworthy relationship. We have to oblige. See, there may be some hiccups in endotracheal tube. Just like this old man, he may be facing hearing issues, but he can hear my silence. The endotracheal tube may create problems, but it will oblige us always. And it is a foolproof device for ventilation as well as prevention against aspiration. So the endotracheal tube says, I am your partner for more than a century, and I am the first choice for obstetric anesthesia. Thanks AOA and thanks Dr. Sunil Pandya and his team.
Yeah, couple of things. Salutations to Meenakshi. Obviously, it is absolutely humorous and interesting. He crossed the points succinctly, but he came up with the evidence from Chestnut, the textbook, and I came up with the articles which came into being published since last 10, 11 years. Obviously, just because the supraglottic airway devices are new, you cannot say no. And things have changed. As I said some time ago, there is evolution happening. We can't still hang on to what Mendelssohn said, because Mendelssohn's era was ether and nitrous oxide, and we don't use such potent emetics anymore. Therefore, the things have changed. Gastric volume tests have ultrasonic imaging have told us that everyone, including non-pregnant women, they have the same gastric volume. Therefore, regurgitation and aspiration will not be a huge issue there. But again, if you want to practice safe, are you willing to take that extra risk when it possibly may happen, the regurgitation and aspiration? Are you willing to take the risk? It obviously, as Meenakshi said, we need not. And as we are aware, the airway changes in pregnancy is so vast. That is why we have moved towards the regional techniques rather than general anesthesia techniques. Therefore, I think there is water in both the arguments, and I think you should not shy away from trying something new. And time tested, yes, it still has value in our anesthesia practice. But be safe. Ultimately, be select your patients, and then you can judiciously use supraglottic airway devices. Meenakshi has left.
Thank you, Dr. Madhusudan and Dr. Meenakshi. It was excellent presentation for both teams. Ravindra sir, isn't it? And we really enjoyed the both team. But what we find is that when we face difficulty in intubation of an obese lady coming with hypertension, and we always think that edema is there, pedal edema is there. So we think of laryngeal edema might be there. So these are a situation, a very elective case, we don't have any tension. But when such type of cases come, we have to think twice, like what are the airway armamentarium we have to keep ready. Then of course we have to keep ready our supraglottic air devices, because again, when we are reluctant to put the electrical tube there, again, there might be your airway edema too in those cases. And so the proper sealing of the LMA most of the time, even we had given multiple times, still we face difficulty, as Dr. Meenakshi has said, like whether it will get fitted to not, or whether leakage will be there or not. Gastric aspiration is a separate issue, but we couldn't ventilate with using our, and again, against Dr. Meenakshi, as he has said, that mask ventilation, we can mask ventilate. Why do use the LMA? But I think that mask ventilating a obstetric patient is also very difficult when you can't intubate. Only on mask ventilation is also difficult. Then LMA also helps us a lot. So I think this is from my side, Dr. Ravindra sir.
Yeah, of course, as both the speakers agree that safety is the criteria. In selected patients, in low risk patients of aspiration, we can always electively use a supraglottic airway device, but not as a routine. Endotracheal tube still stands the standard of care for general anesthesia in cesarean section. This is what we all feel. This is what we all feel. So thank you very much, Dr. Madhusudan and Dr. Meenakshi, for an excellent presentation. Thank you so much.
Thank you.